This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular. We have a nice treat today. Many of you know Fadi, who's director of our stroke program and a vascular neurologist. He's here today to tell us about a really exciting area. One is to remind everybody that stroke is part of a cardiovascular disease, right? And sort of what helps keep us number one. It's a major cause of morbidity and mortality. And it's really an exciting area where there's really been some amazing changes in the treatment of stroke. And Fadi is going to very graciously agreed to come back. He was supposed to be here in December, and we had an inadvertent cancellation of the conference, and we're very pleased that he agreed to come back and tell us all about what's going on. Welcome, Fadi.
Well, thank you for having me, and happy to speak on stroke. I think, frankly, too often from a stroke neurology standpoint, we tend to do things in one location, cardiology in one location, and oftentimes there's a lot of collaboration that we continue to try to foster. So these are my disclosures, nothing really pertinent to the current talk. I thought I'd start with a case, and that highlights a few key things. So a 40-year-old lady presents to an outside hospital, last time seen normal at 10:30 a.m., has a history of hyperlipidemia and depression, active tobacco user for 20 years, no medications. She actually goes to a small rural hospital in North Georgia at 12 o'clock. Great for her that she showed up within an hour and a half, but it's not really a certified primary stroke center. They don't really know what to do. So they actually call a helicopter. The helicopter takes her to a primary stroke center a little bit further south of in North Georgia, and she gets there by 4 p.m. So now we're 5.5 hours out, and they say, we really have nothing to offer. So then they contact us and they say, we need help. Gets helicoptered over to us. And here's the exam when she arrives to us. So now you're talking about 7 hours and 15 minutes after her last time seen normal. Severe expressive aphasia, right visual field cut, right hemiplegia, unable to sense on the right hemibody. And we use the NIH stroke scale as our severity score, and a 19 is quite high and suggestive of a left MCA syndrome. So get a non-contrast CT, and what we've over time developed is more of an understanding of early ischemic changes that can be seen on a non-contrast CT. So for those of you who don't look at head CTs on a very frequent basis, this is the caudate nucleus on the right. Should be bright like that, but you see that the caudate nucleus on this side is actually darker. This is the lentiform nucleus, should be brighter, and you see that it's darker on this side as well. The upper segments, we see a nice cortical ribbon where you typically see more densely packed cells compared to the subcortical region. So she goes to angio. Angiogram shows a left M1 occlusion. She gets reperfused. You get full reperfusion. And the follow-up MRI done within 24 hours basically shows you that she's got an area of restricted diffusion in the area where you saw the early ischemic change. And other than some two punctate areas of infarction peripherally, overall, that whole tissue, which is fed by the left MCA, has largely been saved. 24 hours out, now she's actually speaking in full sentences with some paraphasic errors. He's got full visual fields, still some right lower facial weakness, anti-gravity in the right arm and leg, but not quite full, and some mild decreased sensation. By 72 hours out, she's actually speaking in full sentences with, again, a very mild aphasia. And now she's actually regained full function with some decreased sensation, and her stroke scale has gone to a 3. So with that intro in mind, stroke, for some of you who don't know, has progressively over the last several years dropped from the 3rd leading cause of death to 4th, with chronic lower respiratory diseases taking over 3rd, and trauma actually surpassing stroke more recently, so that stroke is the 5th leading cause of death in the US. Annual incidence is still about 800,000 strokes and rising. most of them first attacks, and it remains, despite this, the leading cause of long-term disability in the US. Now, some of you may be familiar with the fact that we are in the heart of the stroke belt, so named because for more than half a century, we've known that you're 20% more likely to die from a stroke in this region. And there's a stroke buckle to this belt, coastal North Carolina, South Carolina, and Georgia. You're actually 40% more likely to die from a stroke than the rest of the country. More recent data from a large epidemiologic study called REGARDS has shown that it's not higher case fatality, it's just higher case incidence rates of stroke. So again, 20% higher incidence of stroke in this region, and similar 40% higher incidence in the coastal regions here. So oftentimes when I give this talk, I tell people, all right, tell me why you think you're living in the stroke belt in this region. And so when I moved here about 10 years, actually now 15 years ago almost, from California, people used to ask this and they say, we don't know what causes it. I'm like, look at what people are eating here compared to what the rest of the country eats. And so we've been doing some dietary work and research, but there are multiple factors that contribute to this disparity. And this is all sort of a whole separate talk of itself. But for those of you interested, if you Google REGARDS, NIH-funded epidemiologic study, there's a lot of interesting stuff that's been found on these disparities. Now, this is a map that shows you Joint Commission primary stroke centers from a 2010 map, and it's very similar to where things stand currently. The most important thing I want to highlight when it comes to Georgia is we have no lack of certified stroke centers within the Metro Atlanta region, okay? The gap is, look at South Georgia, okay? So it's not an uncommon thing to get a call from South Georgia where basically a good thrombectomy eligible patient is sitting 3 hours by helicopter from any thrombectomy capable center. And so that creates a big issue in terms of getting the patients that need the care to the centers that they need to go. And again, you can see that this is very much spread out with much of the focus of these centers in urban areas. So as we get into talking about acute stroke, an important thing just to again highlight, ischemic stroke is by far the majority of strokes, 88% nationally, 12% hemorrhagic. We have several different subgroups. Large artery atherosclerotic causes makes about 20% of the subgroup of ischemic. Lacunar disease, which is small vessel disease, less likely to be embolic, about 30%. Cardioembolism, 20% by classic history. And then cryptogenic falls 1/3. The cryptogenic folks, more and more studies have shown that if you monitor these people longer term for outpatient follow-up, you're actually going to see about 1/3 of these folks going into having atrial fibrillation. So the cardioembolic cause is likely to be a bigger cohort of this, and the cryptogenic is much more of a smaller cohort with this. And then hemorrhagic, just classically, your hypertensive hemorrhages in the basal ganglia, and then subarachnoid hemorrhage, again, outside of trauma, aneurysmal rupture being the #1 cause with that. So I highlight this when you're thinking about bedside symptoms and stroke type, because you can look at a patient and make a prediction as to whether you think that's an ischemic or hemorrhagic stroke, but there's no 100% certainty just by looking at a patient, whether you're dealing with a hemorrhagic or an ischemic event. I highlight that because still not too infrequently, we see patients who've had neurologic symptoms, and occasionally where other non-neurology specialties will say, oh, you're on aspirin, let me add Plavix and send you over to neurology without any imaging. And it's a very important thing to keep that in mind because from a stroke standpoint, we see much more bleeding than many people realize. So the bottom line is you need imaging. So what do we do from an acute stroke standpoint is the first priority is optimize perfusion. A lot of people don't realize this, but the difference between sitting somebody up and laying them flat increases blood flow on TCDs by as much as 30%. So in acute stroke, you can see people who have actually some disability, and when you lay them flat, much of their symptoms actually resolve. And so that's an important clue that we use to get a sense of how their collaterals are, how much of a time window they have in terms of assessment of their flow. Second of all, whereas you all might say chest pain, chew an aspirin, we tell our patients, don't do anything, just call 911 if you think you're having a stroke. Blood glucose, of course, EMS does that as a routine. Neuroimaging, and I'll show highlights of these. CT is good because it's fast, not because it's very good at assessing early ischemia. MRI is great at acute and chronic. The problem is even in our acute stroke protocol here at Emory, it lasts about 8 minutes. And 8 minutes doesn't sound like much, but having an acute stroke patient lie still for 8 minutes is an extreme challenge. So we typically do not go to MRI on routine basis. And then we go into the vascular imaging here. So what I was showing you in the case was highlighting looking at early ischemic changes on the non-contrast CT. So we can learn a lot about about an acute stroke just by looking at the non-contrast CT. So a group years ago now subdivided the hemisphere into sort of 10 key areas, and based on each area of loss of the gray-white differentiation, what we do is we subtract a score from 10. So the lower the what's termed aspect score, the more and more infarct has basically evolved in those patients. So an aspect score of 10 is great. They have no early ischemic changes, and an aspect score of 0 basically means it looks like they've infarcted the territory. So this is another example just to highlight. We sometimes see an insular ribbon sign where you see on this side the cortical ribbon is a little bit brighter than the subcortical areas. And again, the more you see this, the more it stands out. When you see this for the first time, it may not be as apparent. But the loss of this gray-white differentiation in the insula is a very early ischemic change and a sign of a right MCA stroke in this patient. CTA, fantastic because of the speed we can get it. We can get 3D reconstructions that look as good as a cerebral angiogram. This is a vertebrobasilar stenosis and a 3D reconstruction. So again, we do it in a very rapid way. The discussion about iodinated contrast, its impact on creatinine and kidney function, has over the past few years sort of changed the course of what used to be, oh, they're getting iodinated contrast and their creatinine is this, and that's a major problem. Well, if somebody's in the midst of having a major acute stroke, frankly, forget about the kidneys for a moment, and let's get the vascular imaging and get them what they need for treatment. Now, other large studies have shown that despite a person's creatinine, the iodinated contrast and the impact on kidney function is actually likely to be overblown. And now you have some more radiology studies suggesting that actually the amount of acute kidney injury that occurs from, one run of iodinated contrast or after a thrombectomy is probably not as significant as people tend to look at overall. CT perfusion is another tool and allows us to see basically cerebral blood flow, cerebral blood volume, and mean transit time. All of this is valuable because what I'll show you shortly. This used to be done in a manual way, needing a neuroradiologist, which would basically might take 30 minutes to manually process. And what's developed over time is an automated CT perfusion tool. This is one of them, and this is what we have throughout Emory Healthcare, which is the rapid CT perfusion software. We actually get emails of this data for every CT perfusion that's basically generated across the system. What that basically does is give us, using, and I won't go into the details here, but basically using the time to get to the different regions compared to the contralateral hemisphere, depending on the amount of delay, the areas of green represent the tissue at risk. The purple, based on a measurement of cerebral blood flow compared to the opposite hemisphere, gives you a measurement of the tissue that's likely already infarcted. And so what you want to see is a large amount of green and a small area of that green represented by purple, which is basically imaging mismatch that we see to define the good candidates. Now, in addition to this, when we get emailed this data, we get markers of the amount of delay depending on the different regions, and there's more and more that's been gained by doing that. We get these type of maps that give us each individual cerebral blood volume, blood flow, mean transit time, and Tmax measurements. And ultimately, it's become a very useful tool, as I'll show you in more recent clinical trials. MRI still is your most available sensitive test for detecting acute ischemic stroke, looking for restricted diffusion, hyperintensity in the DWI with corresponding hypointensity. So that's still the best way to assess for an acute ischemic stroke. MRA without contrast is valuable if you don't have an IV and you need something acute in terms of imaging and you're going to MR, because ultimately you can do this and get the vascular anatomy without any contrast. The problem is a 1/3 false positive rate. Add contrast to it, and within Emory Healthcare, our standard for our stroke protocol is an MRA head and neck with and without contrast. So we basically reduce the false positive rate with our MRAs down to 5%. Cerebral angiography is the gold standard. We obviously tend to use it much more for just intervention or when the non-invasive imaging is less revealing for the underlying cause or depending on our level of clinical suspicion. So we get into management. And so when a patient comes in or when you're seeing a patient, and let's say it might be your own patient who's basically in the midst of a concern for acute stroke, we really think about three main groups. Are they IV-tPA eligible? If so, they need to have their blood pressure less than 185/110. Higher blood pressures than this are associated with higher symptomatic hemorrhage rates. If they're not eligible for IV-tPA, then the current AHA recommendations are a goal less than 220/120. These are completely arbitrary numbers. And so you could take somebody who's got a systolic of 240, bring them down to 210, and that increased perfusion from the high blood pressure is actually helping maintain some of that tissue at risk. Bringing them down 30 points may actually be the difference between having anti-gravity strength and taking them to plegia. So a lot of bringing down the blood pressure acutely needs to be very much a consideration of how much are you likely to gain by bringing them down. And this, in people who come in with mild strokes, who have high blood pressures, even the question of giving them IV-tPA and dropping their blood pressure 40 points, you may actually worsen them in the process of bringing their blood pressure down to give them tPA. So it's really a consideration of risks, benefits, looking at their vascular territories and if there is what their collaterals look like before just doing that blindly. In terms of IV-tPA, again, since the 90s, compared to a placebo-controlled trial shown to reduce or to increase minimal or no disability at 3 months by 30% compared to placebo, there is a higher symptomatic hemorrhage rate. FDA approved out to 3 hours. One European randomized trial looked at 3 to 4.5 hours and showed a benefit. The FDA wants a second trial in the US, nobody's going to give placebo. So we practice the AHA guideline throughout Emory Healthcare. Out to 4.5 hours. But again, the longer you wait to give tPA, the less and less the benefit from tPA. One thing that many people aren't aware of is the fact that the larger the severity of your NIH stroke scale or the severity of the stroke, the higher the rate of hemorrhage. When you have a small stroke scale, risk of hemorrhage is only about 2-3%. If you, at the time of the original trial, they were actually enrolling patients who might have evidence of edema on a CT scan. We don't do that at all. That's a well-set stroke in place when there's edema seen on the CT scan. But just to highlight to you, if the non-contrast CT scan shows evidence of edema, 1/3 of those people bled in the original trials. So just because you identify somebody within the 3-hour time window, if the non-contrast CT scan shows that the horse is out of the barn already, just throwing IV-tPA in there needs to be a consideration before just doing it based on time alone. Typically what we do is we go back and say, are you sure that the last time seen normal was 3 hours? And oftentimes the history may not be as actual firm from that standpoint. The time window, as I highlighted, evolves. So if you give tPA within 60 minutes, you double the likelihood for minimal or no disability. By 4.5 hours out, the 95% confidence interval overlaps as if you just gave placebo. We see the same thing with thrombectomy. If you reperfuse MCA or an ICA T occlusion within 200 minutes, 85% chance of a good outcome. As time goes on, by 6 hours, you actually see that the 95% confidence interval overlaps with people who didn't get reperfused. Now, these are averages of multiple patients. The reality is the brain is not being lost in this linear fashion. The reality is you may have patient number one who basically may actually be losing brain tissue very rapidly, and basically they may come in within 2-3 hours time frame, and they've already lost a lot of brain tissue. And then you may have a patient two who may be 12, 16, 24 hours out and who's lost very little brain tissue. Now, in the original paradigm with TPA, it was, well, you come in within this time window and you basically just get the treatment. Nobody knows anything about this, so just go through. Well, people who come in within 3 to 4.5 hour time windows, about 85% of them, based on some studies, will actually have a lot of tissue at risk. So it makes sense for most patients that you just give them TPA. But once you're getting out of beyond that 4.5 hour time window, it becomes really important to differentiate these two types of people. And the big difference between these two types of people is what we call the collaterals. So a lot of people don't realize that if you have an MCA occlusion, your PCA, your ACA may actually be feeding through leptomeningeal collaterals into that ischemic area. And that's the value of the higher blood pressures that actually keep those areas perfusing despite the main artery being occluded. So this becomes, again, a very important way to assess and to triage patient selection for treatment. After the IV TPA time period, then intraarterial TPA was being used. And intraarterial TPA, the original study actually used pro-urokinase. And this is a left M1 occlusion. You get reperfusion. And the original studies showed that intraarterial TPA could recanalize an occlusion in about 66% of the time. There was some bleeding risk associated with that. The first generation of devices came out several years after that. This was the original first generation Mercy clot retriever device. Frankly, sometimes the clot was stronger than the Mercy retriever device, but it was the first generation of it. Then you had a Penumbra system that came out to suction out the clot. And based with these devices, you had actually a fervor for doing thrombectomies and using these devices to see if you could improve patient function. And ultimately, if there was a nadir to the thrombectomy era, in 2013, New England Journal published 3 trials, IMS3, MR Rescue, and Synthesis trial. All 3 were basically negative. And out of it was basically this concern as to, is thrombectomy dead? And the key issues at the time that were realized through those trials was that many of these trials basically were not actually doing a CTA or MRA to look and see if there was actually a clot to go after, a key thing. So you might actually randomize patients who had lacunar disease who had no clot to go after. Well, why would a thrombectomy help somebody with lacunar disease? No evidence for that. No consistent perfusion imaging to evaluate how much tissue was at risk versus how much had infarcted. And there was limited use of Stent-retriever technology. So what is currently the standard of care is basically a Stent-retriever, which basically gets deployed in the clot, and after a few minutes, basically pull out the Stent-retriever, and recanalization can be seen in 80% or more in studies. And the importance of removing the stent is because for acute stroke patients, much more likely to bleed, even giving an aspirin in patients who have received IV TPA doubles your risk for a symptomatic hemorrhage. So we become much more cautious about what you leave in a patient, and rarely do we do acute stenting. In rare situations, we may actually do it because we think you're going to have reocclusion. But with these devices, with an approach that looked at within 6 to 12 hours, with imaging that required CTA or MRA and perfusion imaging, basically 2015 was the opposite. You had New England Journal publishing multiple trials, all showing a positive outcome, and I'm going to highlight to you one of them, which was the US-based one. The key concepts from these, the original ones mostly were within 6 hours, one was within 12 hours. You can't take somebody who's debilitated and in a wheelchair and change that course if they were that way before the stroke, so pre-stroke disability was minimal. CT imaging, again, that aspect score, early ischemic changes had to be minimal. You had to have some disability. So if somebody came in with numbness, you weren't taking them to thrombectomy for isolated numbness. And you had to have, again, CT or MRI confirmation of large vessel occlusion. And you wanted to target at least within 90 minutes of their arterial and perfusion imaging, getting them the groin puncture. Now that sounds terrible for the cardiac world in 90 minutes, but in the stroke world, 90 minutes was a place starter from basically imaging to groin puncture. This is the US-based study. Some of our Emory University at Grady colleagues were a part of this study called SWIFT Prime. And they basically randomized patients who were IVTPA eligible and had a large vessel occlusion with minimal ischemic changes to either IVTPA alone or to IVTPA to thrombectomy. And just a couple of things to highlight about the times. So the biggest delay remains within acute stroke, patients arriving early. So you can see that the bulk of what is almost about 2 hours is just the patient arriving from their last time seen normal. And then you basically see about 55 minutes to get to giving them TPA in the study. And then from there, you have about a 23-minute delay from IVTPA to groin puncture, 24 minutes from groin puncture to first pass. And then once you get first pass, basically within 5 minutes, you open up the artery. We use a TICI score as opposed to TIMI, and a TICI 2B or 3 greater than 50% reperfusion. TICI 3 is 100%. You had 88% reperfusion in the thrombectomy group, 100% reperfusion in 69% of patients. And what we care about most, at 3 months follow-up, the IVTPA treated patients, 1/3 of them had a good outcome. In the thrombectomy after IVTPA, it was almost 2/3, 60%. And as many of you know, within any field of medicine, a number needed to treat a 4 for any procedure of any kind in any location by anybody is hard to come by. And if you look at this is taking people with large strokes to minimal or no disability, but if you look at taking people who are worse and just making them incrementally better, the number needed to treat is actually closer to 2.5. So we've gotten into the habit of when you're taking somebody to thrombectomy and you've carefully chosen those patients, you expect most of those patients are going to have a good outcome. Are we harming people at the cost of helping others? The answer to that is really no. The smaller the infarct, the lower the risk for death. Serious adverse events were similar in both groups. Symptomatic hemorrhage was numerically less, but not statistically significant. So there doesn't appear to be more harm associated with that. More recently, this was just a little more than a year ago. Actually, Dr. Noguera, again, one of our colleagues, led a trial called the DAWN trial. This was to see, well, could you take the same approach and apply it out to 24 hours out? And so basically what they did was they took CTA or MRA, again, for large artery occlusion to confirm it. You used rapid CT perfusion or MRI to confirm mismatch. And then it basically stratified into several groups. The importance of this is the realization that people who might have a small infarct in their 30s, 40s, 50s and can have good outcomes, that, quote, small infarct in somebody who is 80 or 90 years old may actually be large enough to make them debilitated. So there was actually stratification by age, their severity of their stroke, and then targeting in terms of their overall infarct core, a smaller infarct core for those older. 18 years or older, 6 to 24-hour time window, again, minimal pre-stroke disability, and again, the baseline infarct had to be less than 1/3 of the MCA territory. Primary endpoint basically looked at disability scores at 3 months, and the goal was adaptive trial design that looked at anywhere from 150 to 500 patients enrolled with an interim analysis. And the value of that was many of us actually anticipated that with such a small core that you were likely to have a positive outcome with this kind of selection model. Thankfully, the trial was stopped at 31 months after only 200 patients enrolled, and this is basically what we saw. So the median NIH stroke scale, again, this is a fairly severe stroke population, median score of 17. The baseline infarct volume was actually very small, a median of less than 9 cc's, and the median time from last normal to randomization was about 12 to 13 hours. Just to highlight here, most of these patients were enrolled because they woke up with their stroke symptoms and their last time seen normal was officially the night before. So what did we find? Basically, at 90 days, minimal or no disability in the thrombectomy group was almost half of patients. If you looked at the patients who got medical therapy, this was no rtPA, no thrombectomy, only 13%, very statistically significant. And you can look at overall their early response. So again, the early response is basically seeing an improvement in their stroke scale within a very early time frame, within day 5 to 7. Again, about half of patients had that versus 20%. So these are not patients that you're waiting 3 months out to see, do they look better? These are patients who you see a significant improvement very early on. And the subgroup analyses, you can see here through the forest plot, basically you see that regardless of the subgroups, you actually tended to have a benefit with thrombectomy over treating these people medically. Additionally, was there any harm? Actually, again, the theme is you keep the stroke volume down, and ultimately you're less likely, if anything, to see negative outcomes. Neurologic deterioration at 24 hours actually was lower in the thrombectomy group than in the patients who are medically treated. You can see symptomatic hemorrhage at 24 hours was numerically higher with thrombectomy. This was few patients. It was not statistically significant, though. So the key concepts from the more recent trials, which included DAWN and another trial, Defuse 3, was now out to 24 hours out. And now, again, CT perfusion and MR perfusion being a standard in those patients to help in the selection process, in addition to the other elements that we talked about before. So our approach is basically, if you are within 24 hours of your last time seen normal, we're doing a CTA or MRA to basically see if you have a large vessel occlusion. If you have minimal ischemic changes on a CT or MRI, then you're in play for basically being able to undergo a thrombectomy. And now this whole concept has actually been translated even into extending the window for IV-TPA. So this was a trial that was just published within the last few months, and basically was called the Wake-Up Trial. So now you can start to say, well, do I really need to know that person's exact last time seen normal? Maybe I can use MRI to actually time it. So what we know from MRI is you can actually use a diffusion hyperintensity with a corresponding FLAIR normal region in that area. And if you see a diffusion positive, or what we say, a diffusion FLAIR mismatch, then that actually suggests that the patient likely has just been having their ischemic event within the last 4.5 hours. Okay? So this would be what you would look for versus a patient who has a diffusion positive, FLAIR positive, where, again, that would be considered to be beyond that time window. So what this trial did was it says, let's take the greater than 4.5 hours from last time seen normal. Again, as the name implies, most of these patients waking up as the criteria. And anybody who was planned for thrombectomy was excluded, again, because thrombectomy was already proven to be effective at that time if you had a large artery occlusion. And they stopped at 503 of their 800 anticipated enrolled patients due to funding. Now, the one thing to highlight here is they screened 1,362 patients. 2/3 of them were excluded. The most common exclusion for this trial was that they basically had a FLAIR lesion and didn't have a diffusion FLAIR mismatch. So just to highlight that most patients who you're going to take upon awakening, if you take this approach, most patients are actually not going to be eligible because it's probably been over 4.5 hour time window. So it's important not to just assume that most of these patients are eligible for this type of situation. But they took a relatively small stroke type, stroke severity now 6. Again, the volumes of their strokes were very small, 2 to 2.5 cc median. And they treated most patients, again, median time from what was a wake-up to treatment of 3 hours. And what did they find? they found that the people who got alteplase, despite stopping early, actually did have significantly higher likelihood for minimal or no disability in 90 days. Not as dramatic as the thrombectomy data, but nonetheless significant there. The most important thing was that there was actually a trend toward increased death. You can see here 4% versus 1%, and most of this again related to parenchymal hemorrhage type 2. I think the biggest importance of this is I could see where the trial comes back positive because there were such small strokes in many of the patients, but extrapolating this to larger strokes, one I think has to be very careful about patients with larger strokes, even if they're diffusion positive, FLAIR negative. So from my standpoint, the wake-up trial says, you know, now you can evaluate these people who are otherwise ineligible for tPA, ineligible for thrombectomy with MRI if you have rapid MRI available to you. But again, it becomes really an informed consent discussion, understanding about risks and benefits, and especially if that size of that tissue at risk, that core area is larger, you want to be more cautious about giving those patients IV tPA. So the last thing I want to just highlight is just the importance of you all knowing what we have in terms of capability, and also knowing how best to get any of your patients, if they happen to be in the midst of an acute stroke, alerted for us. So all of you know stroke is an emergency. If it's a floor patient, we go through the code met process before code stroke is activated. Any physician who is seeing a patient on the floor who is suspecting acute stroke can themselves activate the code stroke without going through the code met process. But ultimately, the code stroke alert process is an 84700, that's the emergency line. For ICUs, this goes straight to code stroke, there's no code met process. What does the stroke alert get you? It basically gets you a neurology physician, gets you a neurocritical care nurse, and it alerts CT, lab, and pharmacy that we have a potential patient. Stroke alert neurologist, neuro-ICU responder, and basically the CodeMed team work together to rule in or rule out stroke. We want to target, again, IV tPA within 45 minutes if we're going to treat somebody. And the bottom line is we used to call these pages tPA pages. We're well beyond tPA now for acute stroke treatment. So remember that if you're thinking acute stroke, activate it. Don't spend the time thinking, is this tPA eligible? Is this person not tPA eligible in the process? In terms of our outcomes, just to highlight, our comprehensive stroke center here, you can see many of the metrics, and the comprehensive stroke center designation has only been around for about 5 years now. And so they include metrics beyond other centers, stroke severity scores to risk stratify patients. You can see of our patients who get IV tPA or thrombectomy, more than half of them go to minimal or no disability despite having very, very large strokes. Looking at the patients who have intracerebral hemorrhages who are on anticoagulation, getting rapid reversal treatments. You can see that our complication rate post-IV tPA is 0. So again, in terms of patient selection, we do a good job at making sure patients are low risk. Complication post-thrombectomy, again, this would be symptomatic hemorrhages, only 1.6%. Reperfusion, again, 50% or greater, 92% of patients get that. Our median time to groin puncture currently is 78 minutes. This is a combination of patients who come through the ED and patients who are transferred. Obviously, the patients who have a workup and are transferred directly to us to the angio suite are a much quicker time frame than the patients who come to the ED, need imaging, need vascular imaging, get tPA if they're eligible. So those time frames are a little bit longer. Median time to TICI 2B reperfusion, 109 minutes. And then we use nimodipine targets for subarachnoid hemorrhage. This is just to highlight to you, compared to 66 other academic medical centers that are comprehensive stroke centers, you can see we are in gray, they are in red, and you can see the observed to expected mortality rates, inpatient mortality rates are basically significantly lower. You can see here 2016, 2017, and 2018 for all kinds of stroke types, whether it's intracerebral hemorrhage, ischemic stroke, and subarachnoid hemorrhage. So we're very proud of this. And in terms of thrombectomies, we have the full data for 2017 data. If you looked at 90-day outcomes in patients who are eligible for Swift Prime, you can see 91% of them actually had a good outcome. The original Swift Prime trial showed 60% with thrombectomy. Dawn, 100% of the people who were eligible had good outcomes. And again, Dawn had 50%. Now, I want to show you in terms of all cases, this is actually minimal disability in the blue. This is mild to moderate disability, but still able to walk in the pink. The reason all cases is actually lower than these is because, again, these trials were very selective about the amount of core tissue that you could reperfuse. And so we've broadened out in terms of how large the core area is to take patients. We may not be able to get them back to completely minimal or no disability, but if they came to us with 1/3 of their MCA infarcted, reperfusing that rest of that MCA still we think has value, and based on other studies shows that you're still helping those patients despite them coming to you with a larger infarct than would have been eligible for Swift Prime and Dawn. So just want to highlight to you, these are all the accolades for our Emory Stroke Center that have been received, both local, regional, national awards. So we're very proud of these. And many of you know, basically all of our Emory Healthcare sites are primary certified stroke centers by the Joint Commission, except Emory University Hospital, which is our Joint Commission comprehensive certified stroke center. And so we basically transfer patients who are thrombectomy eligible here. And my last slide here is just to highlight that this is a huge team effort. You all are part of that team. And to be a comprehensive stroke center, you have to have all of these capabilities, frequently 24/7 capabilities. And so this is an important piece of having everybody working together toward getting our patients the best care possible. So with that said, as a summary, acute stroke treatment is shifting from a time-based to a tissue-based treatment approach. Acute stroke treatments have significantly evolved over the last few years. And just reminding you that you have an outstanding Emory Stroke team to support your patients in the region. So I know many of you send patients over to us, whether it's inpatient, outpatient. We understand stroke is a high priority in terms of emergent evaluation. And so if you have patients that are outpatient, feel free to contact us directly. We'll be happy to work them in. If you have inpatients, obviously we'll work them in to try to get them transferred over here, whether it's emergently or to try to help out in any other way. So thanks very much for your time and for having me speak.
The preceding program is copyrighted by Emory University.